So today we're talking about local anesthetic systemic toxicity. So what are local anesthetics?
Lidocaine.
Great job. So are local anesthetics weak acids or are they weak bases?
Weak bases.
They're weak bases. Okay, so what does that mean? How does a local anesthetic agent penetrate within the cell? Are they hydrophilic or lipophilic?
Oh gosh.
Lipophilic. Okay, so local anesthetics are weak bases and they're lipophilic agents. So once they penetrate into the cell membrane, they become ionized because the inside of the cell has a higher or lower pH than your extracellular environment. Has a lower pH, so it becomes ionized, and that's how its mechanism of action works. It blocks the sodium channel from the inside of the cell. Okay, so this is great when you're doing a regional block, but what happens when you give a surplus amount of local anesthetic? It can alter what two organ systems?
Your brain.
Your brain and your
heart.
And your heart. Perfect. So signs and symptoms that you're going to see are going to be mainly central nervous system and myocardial. So outside of bupivacaine, your central nervous system signs and symptoms would include agitation, tingling. You're going to see excitation before you see depression. Then as the symptoms progress, you're going to see coma and lethargy. So what types of myocardial symptoms would you expect to see? Bradycardia, which is specific to bupivacaine. However, lidocaine and other local anesthetics that have not as long as a duration of action can cause a slight tachycardia, then it progresses into bradycardia. Why does bupivacaine have predominantly myocardial effects? So it has, remember, it has a high degree of protein binding, and that increases its duration of action.
You guys don't remember this? Come on.
Come on. So number one, when you see a patient that is exhibiting these signs and symptoms, what is the first thing that you want to do? Stop your block, withdraw your needle, and you're going to manage their airway. So number one, airway, you're thinking, okay, I need to get lots of oxygen to their cells. But the real reason as to why you're trying to manage their airway is to prevent them from being further acidotic and preventing hypoxia. Why? Because remember in OB, when we have fetal ion trapping, the same thing happens in your brain. You have a cerebral ion trapping. And physiologically, your CSF has a lesser of a pH, just like your cells do. So that's going to allow them to kind of have this rolling effect and block your sodium channels even more, and that's why you see those CNS effects. Okay, so you manage their airway. Let's say you RSI them, you give them a non-depolarizer, but you saw that they had seizure-like activity. Even though you can't see it, what are you concerned about in their brain? They have a high cerebral metabolic rate of oxygen consumption, so you want to halt that process because that's going to degrade their intracellular integrity. So I would likely want to give what type of agent? A benzodiazepine. Okay, why not other GABA mimetics?
Propofol is cardiac depressive.
Propofol is a cardiac depressant, right? So we already have decreased contractility. Midazolam is likely your best choice. Perfect. So then you're going to institute BLS if needed, and then we're going to give 20% of a lipid emulsion. Why do we give lipids? Let's go back to right, because they're lipophilic and it serves as a sink. So basically the whole theory is that if you give excess lipids, it's going to diffuse away from your myocardial cells, from your central nervous system, if they're not highly ionized, so thus preventing it from increasing in its cascade and serve as a lipid sink. There is this theory too, it's not as commonly referenced in your text, but there's a theory too that it boosts your metabolic effects of your cells because your mitochondria use cholesterol to create coenzyme A, which halts this whole Krebs cycle process. So that's not super common in your text, but that's what current literature is moving towards. So that's really cool. So your 20% lipid emulsion, what are you going to give? What's your dose?
1.5 ml per kilo over 1 minute.
Over 1 minute. So the number one thing that I want you to remember is to bolus it and then start a continuous infusion. So these, as we have had a sheet on the local anesthetic cart or your block cart, that should be given to you. However, just remember bolus and a continuous infusion, 1.5 and 0.25. You can bolus this dose times 2 double it. And the most important thing that I want you to remember is when you give this local anesthetic and they start having a resolution of their depressant effects and they have a great blood pressure and a great heart rate, don't stop the infusion. You want to keep it running for 10 minutes. Your max dose is 10 to 12. Current literature says 12. And then why would you not want to give vasopressors? So,
It can't flow away. There's decreased blood flow at the site of the local anesthetic.
right. So there's decreased blood flow to the side of your local. You're thinking they're already unstable, but they don't exactly understand how epi decreases the effectiveness of the lipid sink of your lipid emulsion, but that's the theory. And then also, if you have contractility, remember, you want to block alpha before beta. If you're giving vasopressors, that's just going to send them into a heart failure-like state. So, any recommendations on preventing this? How can we prevent this in our practice?
Aspiration before.
Yeah, totally. Aspiration before every injection. Wait 3 to 5 minutes after every injection. Ultrasound, yeah, totally. Look where you're going. And then if you can, give any type of IV indicators such as epinephrine, depending on your block.
Also get here on time so your doctor's not rushed to do the block.
Oh, sure. And if you're doing a beer block, only use lidocaine.
Lidocaine, not bupivacaine.
Lidocaine.
Not bupivacaine.
Right.
Yeah,
Does this
totally.
happen?
Test the
It
turn.
did.
Yeah.
It did since I worked here. And so then, whatever you think about, and I know that you've probably read this literature, there is some literature out there that suggests that you just administer a bolus of this, non-measured, of the lipid until the symptoms stop, and then switch to the infusion. Do you have any thoughts on that?
So I think that's real practice, and I think that's what's commonly done, and they've written case reports on it.
So I will say, in practice, when I've used lipids, you program it faster than 999 to go in. So we just let it run.
Oh, yeah.
while open. When we
I
tried to program the pump, it wouldn't program
it wouldn't,
accordingly.
and then it's so thick and viscous.
Right.
So I've only seen this once where they've given it and then they just drew it up in a big 60cc syringe and just gave it and then flushed behind it. So like this is of course the textbook, but in real life bolus, and then make sure that you're monitoring hemodynamically and keep the infusion running. Yeah, tell me.
The only other thing I'd like to say
Yes.
is that as we start heading over to OB in practice, yes, you're going to aspirate if the patient has a running epidural. But I think they get some sort of blood clot sometimes around the end of the catheter. And so when you aspirate, it's negative, and then when you give the first 5 cc's and pause, every once in a while you'll have somebody say, oh, that's a funny taste in my mouth, because the patient's awake. And so I would recommend when we start going over there, if we start going over there, give 1 cc and then aspirate, because it seems like something's happening at the end of that epidural catheter where it's not getting flow. Even if it's intravascular, you can't draw back on it for whatever reason. That's just clinical practice
That's
thing.
yeah.
And
No,
that
I
happened to
agree.
me twice. And then when I pulled back after the patient said that's a funny taste in my mouth, it was like an A line.
Pull it back.
And
Yeah.
she had epidural for 12 hours and I taking care of her the whole day. So anyway.
Yeah, I like that.
What about weight gain with the lipid infusion?
Oh, okay, maybe not weight gain, but that's a really great point. So, if you give lipids, you have to monitor the patient's amylase and lipase because there's a high rate of pancreatitis. So that needs to occur for 2 days. I don't know at what rate for 2 days. I assume just AM labs for 2 days, but it can cause pancreatitis.
Thank you.
You're welcome. Oh, I didn't say that before. I forgot. Please tell everyone.
Also with the note about the vasopressors we were talking about, I think it's not that you can't use like Neo, but vasopressin, calcium channel blockers, beta blockers, and epi are not necessarily your pressors of choice. Does that include Neo? It's not on that list.
So you theoretically would want to stay away from your vasopressors and give the lipid emulsion, because I think this is just a recommendation of saying you're not treating the effect of it rather than you're treating the cause. This is just the symptoms.
All done.
Thank you.
Thank you.